Very good day to all of you. Thank you for giving this opportunity to share with you about Prolieve, which is a study that was done in Singapore. I truly like to thank the chairman of Eurofair for inviting me, Dr. Peng Keng Siang. And this is something that is interesting and new, and hope you benefit from this sharing of Prolieve. So we are sharing with you the early experience of the first safety cases in Singapore, which was a study we did last year. I'd like to acknowledge Dr. Jimmy Beng, who brought the system into Singapore and he opened the system to actually 8 of the urologists who actually joined in to participate in using the system to treat our patients for BPH. We'd like to thank Auriga for actually providing us with actually some funding so that we can offer this treatment at a very good, affordable price to the patients who are actually mainly from the private sector. I'd like to thank Imperial Hospital for providing the endoscopy suite for us to actually do this treatment as a day surgery procedure. But do note that it can actually be done in a clinic if you actually bring the system to your own clinic and treat patients as a truly outpatient treatment. So come to BPH treatment, as urologists, we all know that we can actually do watchful waiting. If not, the symptoms demands it or the condition is bad, you can give them medical therapy. For those who have the right indication, surgery would provide very effective treatment. However, not all patients want surgery, and sometimes medical therapy is just not good enough. We do have the option of minimally invasive therapy. And this is very exciting now because there are many new technologies coming online, and Prolieve is one of them. So looking at the minimally invasive therapy, there are so many of them. We are all familiar with needle ablation, microwave therapy, Prolieve, Rhythm, aquablation, stents, and even prosthetic artery embolism. Here I'm sharing with you about thermodilatation, which is transurethral microwave dilatation of the BPH condition. And we actually have pretty interesting results to share. So you look at it, minimally invasive therapy is, there's a sweet spot for this group of patients, and these are patients who have mild to moderate symptoms but are just not satisfied with drug therapy, either because it's not giving them the adequate relief they are looking for, or the side effects are just very unacceptable for them. Patients who are not keen for surgery, even though it's recommended, can still consider the option of minimally invasive therapy. And for those who are not fit for surgery or even anesthesia, minimally invasive therapy provides a very good option indeed. So the side effects of BPH therapy, we all know those that come with alpha blockers, those that come with 5-alpha reductase inhibitors, and for many reasons, patients are not keen to take these medications. There are complications in TURP, and while they are not that rampant and not usually severe and the numbers are low, they still exist. So of note will be urethral strictures that can be frustrating to patients, and for the younger patients, rapid ejaculation can be a bother to their quality of life after TURP. So the Prolieve system is essentially a microwave heating element combined with a balloon. So the microwave provides heat necrosis to the prostate, while the balloon compresses the prostate to provide adequate heat temperature that can allow necrosis to achieve at much lower temperature. And it actually creates, this compression creates a pseudo capsule which forms some form of biological stent channel, which somehow we found that patients don't need catheter after treatment, and is removed immediately after the Prolieve treatment has been delivered for patient. So this is the Prolieve system. You can actually see the generator device with a screen for us to monitor the treatment and the temperature and the progress of how the treatment is proceeding. This is the coolant system that cools the urethra, and that's why the thermal damage that comes from any other surgery for urethra is not seen. And so that's why it's not common to see a lot of serious bleeding or hematuria after treatment, because there's no real breach of the urethra. This is a cooling irrigant. This is a catheter itself that provides the treatment, and that's the balloon you can see there. And this is the rectal probe that actually allows close monitoring of the rectum. So far, there's no concerns of any kind of fistula of term or injury to the rectum, and it really allows us to have very safe confidence in monitoring the system. So this is what you see. The catheter goes in, and the balloon sits here, providing compression and dilatation of the channel here. This balloon helps you to secure and locate the position where this dilatation balloon should sit, and inside is a microwave heating element. So this balloon allows us to actually not use an ultrasound, but we always use an ultrasound just to be safe, just to be sure where we are, that the balloon is in the right position. And this is my patient with the catheter in place, and they are actually awake. So the EAU 2018 guidelines have already shown that transurethral microwave therapy can actually achieve symptom improvement comparable to TRP. However, of course, TRP have a much longer duration in terms of benefits as opposed to earlier recurrence of symptoms in microwave therapy. We'd like to take a look. Hospitalization time, hematuria, clot retention, transfusion, sexual dysfunction, retreatment rates for urethral stricture and bladder neck contracture were significantly lower in TUMP, and that's something that is important to note. TUMP is indeed a true outpatient procedure, and it's an option for elderly patients with comorbidities or with great anesthetic risk, and this is actually the comments by EAU guidelines. So it is a fast procedure, about 1 hour, and it's completed. It's done under local anesthesia. You can give sedation if you choose to. More than 100,000 cases have been done in the US, and by now a lot more have actually also been done in the world. And 94% post-treatment were catheter-free, and there's minimal side effects. So for younger patients who are concerned about retrograde ejaculation, even erectile dysfunction, the incident rate is very low. And this is a study comparing TUMD, which is a Prolieve, against finasteride, and a significant clear difference between the AUA score for finasteride treatment and TUMD or Prolieve treatment. This is a MRI thermal mapping of the energy and necrosis in the prostate, and you can see that temperatures are much higher at the bladder neck and the mid-gland, which is the area that we like to treat, and we don't want it near the apex, which can cause incontinence, which is demonstrated here, and you can tell that temperature 7 millimeters away from the prostatic urethra is actually pretty safe, and that's why the risk of stricture is low. This shows you the micturating cystourethrogram that shows the pre-treatment and post-treatment or Prolieve treatment, and show a wide open prostatic urethra, what we call the biological scan. So there are 5-year post-market study by Prolieve in the group of patients who are of average 65 years old with a prostate of about 40 grams. Results are actually as shown. 85% did not require catheterization after Prolieve. So that's very encouraging for patients who cannot imagine going home with a catheter. You can see the AUA score improvement is significant over 5 years, and actually maintained through the 5 years. Quality of life is also significant and maintained through the 5 years. There's no change in the PSA levels. I can see that peak flow rate interestingly increased over the 5 years. Another study looked at very high-risk patients who have a median ASA of 3. And these patients were more than 75 years old. The median age was 76.9 years old. And these patients had BPH. Out of 107 who were catheterized, 63% were successfully trialed off. And of note is actually all these patients had some form of anticoagulation. 86% had antiplatelet, 24% had warfarin. So our Singapore early experience started in July last year to July this year in Farrer Hospital. We were done as day surgery under local anesthesia. 1 or 2 patients requested for sedation, which we gave, and they actually fared very comfortably as well. So there were 8 urologists involved in this study, 50 patients in total. And bearing in mind, we weren't just doing Prolieve, we continued to treat patients with TRP and medicine for our patients with BPH. So the age of this patient, the average was 67 years old, ASA ranged from 1 to 3. The average prostate volume was 50.1 mils, ranging from 21 to 80 mils. The results were actually very encouraged. 2 patients needed catheter after treatment, only 2. There was hematuria seen in 9 of the 50 cases, which resolved in 1 to 2 days. Similarly, 9 of the 50 cases had dysuria, which again resolved in 1 to 2 days. 1 case had hematuria for 7 days. For pain score of 1 to 2, 8 patients complained of some form of pain, but they were minor, only a 1 to 2. Talk about average Qmax change was actually 2.2 mils, but they varied because the maximum actually change was 18 mils per second. So with better selection and depending on the cases, we are doing a sub-study to see who are the patients that can really have a change in Qmax or Euroflow. But we also noticed that for a lot of patients without a significant change in Qmax in their Euroflow, their symptoms actually improved by a fair bit. So the pre and post-op IPSS pre-op average was 20, post-op was a very encouraging and good level of only 6. Complications, as mentioned, 2 patients needed post-procedure catheterization. 1 patient actually failed the procedure, which we'll go into in details later. He was already catheterized pre-operatively. 1 patient had a catheter inserted for bladder irritation. Patient was not in retention and it was subsequently removed after 1 to 2 days, and he was successfully voiding after that. There was 1 out of 50 cases had urine tract infection, that's 2%, and there's no reported need for transfusion, stricture, or rapid ejaculation thus far. So looking at some case examples, this is an 84-year-old Chinese male, prostate volume of 42 mils with a significantly bad IPSS of 33, which improved to 3 after Prolieve. Qmax from 15.9 improved to 20.5, and residual urine dropped from 44 to 11 mils, as you can see from the graph here. The other one is a Frenchman, as an example, 61 years old, fit Frenchman, 37.7 mils. Why did he choose this? Well, clearly in his case, he was very concerned about sexual dysfunction and really didn't want any significant surgery done. So this was a suitable option. And his IPSS improved from 29 to 16. Qmax also improved from 14.5 to 20.3, and residual urine dropped from 76 mils to 13 mils. And you can see this strain pattern versus a fairly comfortable, less not obstructed picture being shown. In this case, it's a patient of mine who had a high bladder neck for 45-year-old. He's an Italian man who's been suffering poor flow and very high residual urine. UBS actually showed significant bladder outlet obstruction of 90 centimeters water. Prostate wasn't that enlarged, was only 25 mils. Scope actually showed mainly high bladder neck with mildly obstructing lateral lobe, but he really didn't want surgery. So initially he improved with alpha blocker, IPSS from 19 to 7, but then he started progressing to 11 again, and he was considering what else can be done, and his residual was actually still high at 151 and 106 over 2 voids. So he chose Prolieve, and after Prolieve, well, the flow was actually almost the same. Initially it was a bit worse, but it got back to the same level. Residual urine actually improved, but from a IPSS symptom score point, he wasn't that satisfied, and he's actually considering a bladder neck incision after this. This was a case of a patient who was pre-operatively in retention. Before that, ultrasound report did not report a median lobe, and he actually underwent Prolieve. And after Prolieve, he was the case that was reported to require a catheter for post-procedure retention. So he underwent a TRP after that and was voiding well after that. This is the histology that was done that showed that actually there was significant diatomy effects or coagulative effect on the prostatic chip where the microwave treatment was actually delivered. So we do know that from that actually median load, even from Prolieve recommendation, patients with median load should not be considered for Prolieve treatment. So looking at this, Prolieve is treatment that is truly outpatient in setting, as opposed to many MITs that still require sedation or actually rigid equipment for doing the treatment. For high-risk patients, it's a very good alternative because it only requires local anesthesia, pretty much the gel that we use for catheterization. And patients who are on antiplatelet or even warfarin, still on anticoagulation, it is still fairly safe. The numbers, as I showed from the US, is actually very shows that it can be safely done with good outcome. Cost-wise, it's a self-contained system. There's no requirement for any endoscopic or rigid equipment. It's just the catheter. There's no need for an operating theatre or actually endoscopic facility, and the manpower is minimal. And there's no need for sedation or general anesthesia, minimizing anesthesia charges. There's no implants to remove, so compared to stents or other MIT procedures, if there's a need to remove anything, a patient you will have to undergo another procedure for it. It may not be fit. So for patients who really cannot afford to go to the operating theatre, Prolieve is a very good alternative. There's no need for post-op catheterization. So for procedures that require post-op catheter, uh, a patient who's catheter naive, who never had a catheter, you actually have to put it for 5 to 7 days. Post-procedure is something that they may not accept. So really the take-home message is Prolieve transurethral microwave dilatation has been found to actually change the natural history of BP progression. It provides an alternative, truly outpatient MIT treatment for patients who are not keen on medication and who suffer too much side effects from the medication, who are not satisfied with the medical therapy results, who are not keen for surgery, or who are high risk, whereby surgery is not an option. So our early Singapore Prolieve experience shows that there is safe and encouraging results with good patient satisfactions. The results can definitely be improved with better patient selections, and large median lobes are not suitable. Patients that need surgery are still advised for therapy unless they are unfit. And with that, I really want to thank you for this opportunity to share with all of you. And it's really my first experience sharing online, so it's a bit weird if I have a fairly expressionless face. So thank you very much, and look forward to meeting all of you when the world opens up again. Thank you very much.